Hi, I'm Prita Jimelinda. Good morning. In this section, we will talk about a placenta accreta spectrum disorder. So according to the ACOG, placenta accreta is defined as abnormal trophoblast invasion of placenta into the myometrium of the uterine wall. Placenta accreta spectrum, formerly known as morbidly adherent placenta, refers to the range of pathologic adherence of the placenta, including placenta increta, placenta procreta, and placenta accreta. The terminology of PAS disorder or placenta accreta spectrum disorder is actually already has been changed for ages, and finally FIGO issued the recent and acceptable terminology for this placenta accreta as placenta accreta spectrum disorder that is used worldwide. So before we are going to talk about the adherent or the degree of invasion of placenta accreta spectrum disorder, let's see. Here is the normal placental invasion. There is a placental section here, and then middle section and maternal section. There's a coronal plate which is faced to the fetal part, and this is the phylus parenchyma where the exchange happened between the umbilical vein and arteries into the villi, and then meet with the endometrial arteries and veins and do the exchange here. And also there is a basal plate where the endometrial arteries and veins arose. And this is the uh, last part of the decidua, and the deeper part, the outer part is the myometrium. So the normal placenta invasion will only until the basal plate of decidua, and it will not going to enter the myometrium. So here is a diagram of the differences of of invasion of the placenta. There is a placenta accreta, increta, and percreta. There is a normal placenta invasion, which is only into the endometrium in the basal plate, and it's not entering any part of the myometrium layers. Where the accreta is already invade until the full thickness of the endometrium and already in the lining of the myometrium layer. Increta is an invasion of the placenta that is already in a halfway of thickness of the myometrium. And the last is percreta, which the invasion of the placenta is already full thickness of the myometrium until it can be pushed into the outer side of the uterine, which will allows you to visualize it easily in the Durante operation. So now we're talking about the etiology of PAS disorder. So there are so many hypotheses there about the PAS disorder etiology, but the most recently acceptable etiology is a defect of the endometrial myometrial interface that leads to a failure of a normal decidulation in the area of a uterine scar, which allows abnormally deep placental anchoring villi and trophoblast infiltration. So this etiology is actually on their uh, in, part of the NK cells functions abnormality. So in the normal way, the NK, or we can say as UNK cells, it has a double function, multifunctions, and they are going to regulate in a balanced way. But whenever there is a disruption here and they lose the balance of the function of the activation and the limitation, there will be a disorder. So what disorder that came up with the NK cells abnormality of balance of function? Let's see. So we are talking about the interaction of UNK cell and trophoblast. UNK cells regulate trophoblast invasion through the secretion of angiogenic growth factor, cytokines, and chemokines. What angiogenic factors they are? Well, the angiogenic factors of UNK includes the VEGF or vascular endothelial growth factor and PLGF or placental growth factor. And the UNK cells participate in uterine spiral artery remodeling by promoting dysangiogenesis at embryonic implantation sites by means of a gradient of cytokines and vasoactive mediators. So as we can see, there is an site here, the implantation site here. During angiogenic activation, hormone factors and the hypoxic setting, which is the place that is really good for the implantation, not good actually, bad implantation, because there is an hypoxic setting of the implantation site, are also capable of regulating the production of angiogenic factors such as VEGF and their interaction with endothelial cells. Why it is important? Because this hypoxic setting or this hypoxic site will um, later we talk about, and it is one of the risk of the placenta accreta disorder. Specific trophoblast recognition is carried out by UNK cells, which has the double function, that is the activator or inhibitor receptors. Whenever the function as the activator receptors is stronger than the inhibitor, so it will be activated. So the angiogenic growth factor, cytokines and chemokines will lead to uncontrolled trophoblast invasion, which will lead to placenta accreta. Meanwhile, if the inhibitor receptor is stronger, if the inhibitor's function or action is stronger than the activator receptors, it will be inhibits the trophoblast invasion into the endometrium. So, what is the disorder that we can have here is the preeclampsia. So whenever you have too much activity, you will have the placenta accreta spectrum disorder. But if you have stronger inhibitor activity, you will have preeclampsia. So now we are talking about the risk factor of PAS disorder. First is prior CS or cesarean section. This will lead you to have a niche. In this diagram, we can see a niche is an indentation of a previous cesarean scar site, which the depth is at least 2 mm. So this site will have a higher risk to be implanted by the fertilized oocyte, and then of course it will grow as an ectopic pregnancy, and the placenta will uncurling there too. So because of this thickness is smaller than a normal thickness of uterine walls, this will be really a risk factor of you to be developing a placenta accreta. And then the second risk factor is advanced maternal age, multiparity, prior uterine surgeries. This is the same as I said before. This is the prior CS. Any other uterine surgeries that open the uterine will allows you to have a risk factor of PAS disorder development, and also a curettage. So any other uterine opening or entering the uterine, the action of entering the uterine will lead to a scarring of the uterine wall, and you will have a higher risk factor to develop a PAS disorder. Asherman syndrome is also a risk factor. This is the condition when the uterine will have many adhesion because of the prior curettage action. So just like any other uterine manipulation, surgery, curettage, entering, opening, all of them will lead to a scarring, adhesion. So it will be the risk to be a placenta accreta. Now the question is about nulliparity. Okay, the multiparity is reasonable because okay, there is a history of cesarean section or history of uterine surgeries, curettage. But how about the nulliparity? This is still in a debate, and we have to search more about the reason why past disorder can be found in nulliparity too. Now we are talking about CSP versus PAS. Well, as I said before about the ectopic pregnancy that is implanted in the niche, if it will be grow into a fetus and so on, it will be called as CSP or cesarean scar pregnancy. It is it is actually categorized as ectopic pregnancy because it is not in the uterine and in the uterine, but is in the niche or in the past scar of the cesarean section. And how about pus? Pus is placenta accreta spectrum. So the term of pus is only refers to placental invasion abnormalities in the second and third trimester, while the term CSP is used for the first trimester due to prior CS because this type of ectopic pregnancy will later develop into placenta accreta. So as long as you found the abnormality in the first trimester, you will call it as CSP, and it will be grow and have a risk to be later developed into a placenta accreta. But whenever you found the placenta is already uncovering there in the second and the third trimester, so you will see the the invasion of the placenta, you will use the term PAS. So now we are talking about the pathogenesis of PAS disorder. The pathogenesis of PAS disorder is divided into 5 stages. The first stage is niche or pre-pregnancy. So as I said before, the risk factors play roles here, like the surgery-related factors, like I said before, the CS, prior uterine surgery, and any other thing of uterine opening, uterine entering, like curettage, will relate it to this stage. And also there are other factors which is maternal or patient-related factors. The second stage is conception implantation. So there are fibrinoid deposit layers in the uterine, that is Langhans, Rohrs, and Neitbach. The damage of the decidua basalis and Neitbach layer will lead into the unbalanced invasion of the placenta. The Neitbach layer here is really play a role in limit or inhibits the invasion of the placenta. So whenever there is a damage of this decidual basalis and Neitbach layer, there will be no limitation or no inhibition of the invading placenta into the myometrium. And this impaired decidual layer development, tropoblast excessive invasion, or both can happen in this stage. The third stage is increased immunogenic factors, like we talked about the etiology before. There are so many chemokines, cytokines, and phagogenetic factors, VEGF, PLGF, that play roles here. And the stage 4 is imbalance of growth factors and inhibiting factors. In Like I said before, the UNK or decidual natural killer cells play roles here because um, there is a imbalanced action of the growth and the inhibiting. So whenever there is an imbalance, the growth is stronger than the inhibition, it will be leads into the placenta accreta. The fifth stage is massive vascular collateral system. So this is a high grade placenta accreta. I mean, there is already a collateral system there. So the vascular is not only limited in the placenta and in the metrium, myometrium, but already collateral with the big vessels, like the bigger vessels, I mean, like the uterine and arcuate is already dilated, uterine arteries, and so on. So now it is about a PAI, or Placenta Accreta Index. Placenta Accreta Index is a standardized approach to prenatal diagnosis of PAS, incorporating clinical risk and ultrasound or US findings suggestive of placenta invasions. So there are so many parameters that we used in the PAI. One of them is the more than 2 cesarean deliveries, which we already talked about it in the risk factors. And the other parameters is actually by using the ultrasounds finding, like lacuna and then sagittal smallest myometrium thickness, which divided into three value here, and then anterior placenta previa and breathing vessels. So the diagnosis of placenta accreta spectrum disorder can be obtained by using the modality of USG and a Doppler, and this can be done both in the early pregnancy or on the late pregnancy. So in the early pregnancy, we can determine the GS location, whether it is in the upper or in the lower part of the uterine, and is there any TSP, by using the transvaginal US. So I'm sorry if my drawing is bad, but I hope you understand. This is the first visualization of the uterine you can see from the transvaginal USG. And then make an imaginary line from the fundus into the external os of the cervix and divide it into the half like this, and this will be the upper quadrant, and this one will be the lower quadrant. So when you see the implantation or the gestational sac location is in the upper quadrant, there will be likely to be a normal pregnancy, right? Because this is the normal site of implantation. But if you see the gestational sac is in the lower segment, lower quadrant, moreover, if it is in the anterior wall of the uterus, which is we know that the incision of cesarean section is usually done here. So this will lead you to have a niche, and then the gestational sac is implanted here, and this will be going to be the CSP, and later on it will develop into the placenta accreta spectrum disorder. So the next is the in the late pregnancy, you can use the abdominal USG to measure the myometrium thickness. So the take-home message here are the preconceptional and family plannings are really important. So before you're going to be expected, if you have the risk factor that listed before, it's better for you to see your obstetrician and consult your pre-pregnancy to the expert. And the early screening and diagnosis can be done by using the transvaginal USG, using the imaginary line, and divided into 4 quadrants like we talked about before. And if we found it in the early year pregnancy, we can do the action, whether we can terminate the pregnancy before it grows into the placenta accreta spectrum disorder, or whether to refer the patient to the higher facilitated hospital, because this is not about the best doctor to cure this problem or to handle this PAS disorder, but it is about the teamwork. And there is a suggestion to make a high incision lower segment uterine for the CS incision rather than in the lower incision, because it tends to decrease the risk to develop into the placenta accreta spectrum disorder. But in the other hand, it also can increase the risk to be a uterine rupture. So it is still in a debate. So once again, thank you very much for your attention, and I hope you can enjoy this section. Goodbye.